Thanks, Hans. I think when people introduce you as not needing introduction, that means that hopefully you're one of the more senior people in the field and not one who's aging out of the field. And I guess when you get to my age, you tend more to reminisce. And in fact, as Hans was speaking earlier, it occurred to me that the therapeutic goals came out from a meeting of Hans and a few other colleagues in Amsterdam over 10 years ago. And when Emma mentioned South Africa, we remember with fond memory Joe Tager, who perhaps we'll hear more about, who was one of the luminaries in the field in the immediate decade, actually, preceding the introduction of therapy. And he had been around for some years thereafter, and was in fact Hans' mentor. These are my disclosure. So I think when you look at quality of life in patients with Gaucher's disease, I think you have to look at it in relation to the burden of disease. And I think we've heard some of the new ones associated with that from Emma's presentation and also Tanya's presentation. But in the era when therapy is available, we obviously have to understand how effective treatment is and what are the burdens imposed on the patient by committing to treatment in this situation, for example, where we have a treatment but not necessarily a cure. And with enzyme replacement therapy administered intravenously, obviously some encumbrance associated with that. I'll sort of just briefly talk about this conceptual framework that I sort of drew up when I was asked to prepare this talk. I will not go into great details about health-related quality of life assessment tools, because what I've really done is go back into the published literature about what studies have looked at quality of life or health-related physical and functional well-being in patients with Gaucher's disease. And I'm sure most of you are aware, this is largely with SF36, which is actually a generic, not a patient-specific or patient-specific reported outcome measures. But I think one should also appreciate that when you look to quality of life instruments, at the end of the day, any conclusions you can come up, whether with quality of life instruments or with PROM, patient-reported outcome measures, apply more to the group, not necessarily the individual. And so you look at the impact, for instance, of the disease and its treatment in terms of the group. And I think that probably has come about because obviously for Gaucher and other diseases, there is broad heterogeneity in clinical presentation, and the rate and magnitude of benefit to any treatment will individually be very different. And the last point in terms of then and now is to emphasize that most of the studies on health-related quality of life in patients with Gaucher's disease largely looked at adult patients during the first decade when enzyme therapy became available. And I think what we'll probably hear today and tomorrow, and also got a feeling for from some of the earlier presentations from Ari and our other colleagues, including Don and Jordi, is the fact that the phenotype has been transformed by enzyme replacement therapy and early diagnosis. So in many ways, perhaps the burden of disease is not what it was before when it was closely looked at. And that's just to remind me that perhaps we now need to re-examine again both generic and patient-specific instruments to assess quality of life in patients with Gaucher's disease. So I think when you look at quality of life, you obviously try and better understand what is the burden of disease, the disabling complications or health-limiting problems patients have, not only on the physical, but also emotional and mental well-being of patients. And go on to assess those with available instruments, with fortunately the availability of treatment and potentially options. What is the encumbrance or burden in itself associated with therapy, and ultimately the impact on physical and functional well-being. So I think we've heard this morning that the primary drivers of morbidity in Gaucher's disease are anemia, thrombocytopenia, hepatosplenomegaly, and bone disease. There are comorbidities, and as was alluded to, sometimes we will have a patient who's diagnosed with Parkinson in the 60s without necessarily a family history or recognized family history of Gaucher's disease, and without the diagnosis of Gaucher's disease, and ultimately identified as either a carrier or affected. There are certain disease severity scores, but I won't dwell on this in great detail, except again to emphasize the broad heterogeneity in clinical presentation as a potential issue when looking at groups of patients and limitations associated with trying to interpret what outcome measures might mean. But I then shift to emphasizing bone-related complications because most of the studies indicate that perhaps bone-related complications, including those that are irreversible when diagnosis is delayed or perhaps treatment is suboptimal, complications such as osteonecrosis, pathological fracture, affect quality of life substantially. And indeed, when you look at those disease severity scores, what you begin to realize is that the weight of bone involvement accounts or has a greater impact on quality of life than hematologic and visceral manifestations, and in fact, weighted to an extent ranging from greater than 17 to 27%. And I guess I sort of briefly dwell on this because people have looked at quality of life, and in this case from the group in Spain, again, primarily adults ranging in age from 18 to 66, including 16 who've had their spleen removed, but 60% had varying degrees of bone involvement. And in fact, if you look at the group as a whole first, what you realize for the Spanish population is the red line indicating their current quality of life. And I don't know, this is probably pre-economic crisis data. But in any case, as you can see, both for the physical and mental domains, it is quite reduced. And in fact, almost no overlap except when you go to social functioning. And interestingly, role emotional is significantly reduced. But mental health, and this is largely type 1 patients, seems to also not be significantly affected. But then when you kind of try and better understand what are the significant points, bone pain stands out. And in fact, you also see here a correlation with increasing severity of bone disease. But even mildly affected patients with respect to bone or have very minimal bone involvement clearly also have a significant reduction in their quality of life, perhaps attributed to hematologic and visceral involvement. So several years ago, in collaboration with Ann Damiano and John Ware, who actually developed SF36, we were curious about quality of life, and these are largely from American patients. And in our own study, we didn't really see a significant involvement of the component of the domains associated with the mental component score. And what we saw were primarily physical scores that were significantly reduced. But what I've superimposed on this data are two aspects about the phenotype of the disease. When treatment first became available, a significant proportion of adult patients had already advanced disease, which meant that they've either undergone splenectomy or a hip replacement because of significant joint involvement, subchondral collapse, bone pain, and limited mobility. And in fact, what you kind of get from this is that the physical functioning and quality of life in those patients are further reduced, and that intuitively makes sense. So if you look at tools to measure quality of life, as we've heard this morning, there are generic and disease specific. SF36 is what you find when you search quality of life and Gaucher disease publications, perhaps because it is most widely used, validated across populations. So we use the English version, the Spanish use the Catalan, the Spanish version. I've become a rebel since I moved to Ireland, I guess. my frame of mind is being molded or transformed. But the beauty of a generic instrument is the ability to compare with specific diseases of interest or other chronic conditions. I mean, you have to understand the backstory about quality of life instruments. Like I said, if you had a treatment that was spectacular, that you only needed to use for 5 days, and there was no doubt about the benefit, and you didn't need to prophylax and you didn't need chronic therapy, we won't need quality of life instruments because it's so obvious. You only need it for chronic conditions because there isn't a cure. But the value of this, as we've heard as well, is that most regulatory agencies, when looking across their population, are kind of interested, well, how do we allocate healthcare resources? So in any case, I think most of quality of life instruments, including SF36, really tells us essentially, largely, the patient's health status. And there are set values corresponding to patient's perspective, but we don't really get the nuance of how the disease itself and the commitment to treatment is affecting the patient's psychosocial well-being. This is just a listing of other generic instruments. And I thought what was interesting about this is that when you kind of look at the domains, and there's 8 there for SF36, much more limited for the Nottingham score. But then when you go to the World Health Quality of Life, it's interesting that they talk about the environment or the milieu within which the patient is living and engages with. And then also, obviously, the spirituality. And, that is whether you believe in divine providence or not, it's immaterial, because it's really more the concept of what spirituality is rather than its association with any particular deity or faith, as it were. But in any case, it turns out most of these generic instruments that talk about health profile can incorporate a score which will transform it into utility measures that will allow cost-utility analysis. Specific instruments might be more clinically sensible, and we'll hear perhaps more about this from Debbie Elstein later. But as you can see, when you look at what people say about disease-specific instruments, is the inability then now to not compare your specific condition with other chronic conditions. Like, for example, in another study, we looked at health-related quality of life in patients with Fabry and compared and contrasted those to patients with Gaucher. And perhaps because of the end organs affected in Fabry, we in fact even got worse scores with also a significant impact on the mental component score. Specific instruments may be more responsive than generic instruments, but then be limited in terms of population and intervention or stratifying patients. But again, I think we're moving in that direction because most generic instruments are felt to not necessarily focus adequately on disease-specific areas of interest, and as such may not really show a significant change, even though, as we've heard from Emma, treatments have been transformative, and not only has it altered the natural course of her condition, but also brightened her future prospects. So there are cardinal values to utility measure, which is a range, interestingly, from 0 or death to perfect health. And most of us are probably somewhere in between. But as we've heard, I think most third-party payers and regulators are interested in health economics. And I won't even dwell on quality of life adjusted years, which is an interesting body of literature when you look to how they arrived at 40, 45, or 50,000 as quality of life adjusted years in terms of what is a cost-effective therapy across different indications. But if you look to zero or death as the worst outcome, it begs the question, is Gaucher disease a life-limiting condition? This is a study that was done in the United States from data in the registry. And in fact, there is some decrease in life expectancy among Gaucher patients, but this might be largely driven by those who have developed a malignancy. And you'll note, which Ari already pointed out, multiple myeloma in that listing. And in fact, I guess they don't necessarily list Parkinson as a comorbidity because most people in the end, I guess, will die from cardiorespiratory failure, whatever their initial diagnosis is. So let's look at treatment, and I won't really have a lot of time to talk about this, and I think I see on the clock that maybe I've gained some time, which will be good, I think, because then we'll have more time for discussion as well. But in relation to this paper that I talked about earlier, which looked at quality of life, this came about when treatment also first became available. And I think what you can see here is a shift from worst health status to the best health outcome. And then over year 1, year 2, and year 4, an increase in the proportion of patients who are continuing to do well. Even though, in fact, about half of these patients were already patients who may have had a splenectomy and or significant bone complications such as a vascular necrosis. So I hope, and I think most of you already appreciate this, that Gaucher as a health problem can have a significant impact on quality of life, that a major driver of physical and functional well-being deterioration, or a deterioration in physical and functional well-being among patients with Gaucher's disease is largely perhaps because of bone complications, and we didn't really even talk about comorbidities like Parkinson. But fortunately, treatment is effective in reversing the cardinal features of disease, which we appreciate has a positive influence on quality of life. And when the diagnosis is made early and treatment initiated early, you hopefully obviate the need for a splenectomy and then prevent the development of insidious bone complications. But in looking back to these studies, although there are a lot of studies reporting effectiveness on primary or traditional physiologic measures of disease, there's very little that has looked at burden of treatment itself and what it means to commit to intravenous therapy. And perhaps with the expanding therapeutic options, this will be an issue again that will be examined to make sure that we factor into any decision as patients become more empowered and engage in discussions about therapeutic options, what their perception is of the options and their response. And I think I'll end there. Thank you.